Hey everyone, this is Jason from Intricate Art Spine and Body Solutions. I just wanted to talk to everybody today about treating the upper cervical spine and the cervical spine in general along with the occiput, specifically for sympathetic autonomic hyperactivity, but that can be expanded out into headaches, brain fog, dizziness, loss of balance, visual deficits. The cervical spine in particular has a very, very direct negative effect on brain function when it's pathologic, and that holds true for the pelvic floor too, right? So remember, the pelvic floor and the jaw are two of the most parasympathetic areas of the body, and the reason the jaw is because of the trigeminal nerve. So that's one of the reasons that the upper cervical spine is also considered a parasympathetic dominant portion of the autonomic nervous system, because if we're thinking about it here, right? So my thought as far as so many chronic so-called idiopathic conditions or impairments that people have that is not specifically related to a recent injury, right? So even if they have had an injury in the past, like a car accident or whatever, if that's been healed and they're continuing to have impairments, whether it's, again, brain fog, upper cervical problems, it's all secondary to autonomic nervous system hyperactivity of the sympathetic side of it, right? So sympathetic autonomic nervous system hyperactivity. The reason that pathology in the cervical spine can be so problematic for people, there's a couple of different reasons. I think that the amount of nerves and mechanoreceptors that we have in the cervical spine is a lot more than we have elsewhere in our body. So number one, we have a lot more proprioception of our cervical spine. We have more mechanoreceptors. The cervical spine moves more, so it's going to pick up on pathology better, right? And as far as distance to the brain, obviously this is pretty close to the brain here, right? So those nerve signals, the negative afferent nerve signals going up from the muscles, crossing over substances and things in the dorsal horn of the spinal column, like the trigeminal cervical nucleus, right? That can cause all sorts of issues, and they present differently on different people. So remember, if we're looking at the head here, right, my finger right on the front side of the vertebrae, that's where the glossopharyngeal nerve comes out, the hypoglossal nerve, the spinal accessory nerve, the facial nerve, and the vagus nerve all come out of the brainstem, and they travel right on the front side of the vertebral bodies, and then they travel down into their respective areas, right? So if those nerves are getting negative stimulation from hypoxic, inflamed tissues, if they're getting too much epinephrine, if they're not getting enough blood supply, those muscles and the nerves themselves become pathologic. So nerves need blood just like muscles do, you guys remember. So we can't treat muscles right on the front side of the cervical spine, right? Our trachea is there, that wouldn't work out too well. But we can treat muscles starting from the transverse processes and moving back, right? So this model is a pretty good one. You can see, I'm going to paint the sympathetic chain on here. So the sympathetic chain would be like my first finger. Here's the brachial plexus and the cervical nerve roots. Here's the transverse processes, right? So when we talk about spinal manipulation in the cervical spine, we just talk about the articular pillar, which is kind of in between the spinous processes and the transverse processes, or on the back side of the transverse processes. So if the cervical musculature gets aggravated, so the first muscle that we can needle on the back side of the transverse processes is the middle scalene, right? The anterior scalene and the middle scalene make a sandwich out of the cervical transverse processes, and that's also where the phrenic nerve comes out, right? So remember, C3, 4, and 5 keeps you alive. Those are the primary nerves that innervate our diaphragm, right? So if the middle scalene gets tight, which we can needle the middle scalene, again, remember, as far as safety goes, we want to start the needles behind the transverse processes because there's no major neurovasculature behind the TPs, right? All the stuff, the first major thing is the vertebral artery straight through the transverse processes there, and then we got the brachial plexus and the nerve roots on the front, right? So from the TPs backwards, that's where we can needle. So the middle scalene attaches right like my first finger here, right? It attaches on the posterior aspects of the cervical transverse processes from C2 down to the first rib. So the middle scalene is sort of oriented just opposite the sympathetic chain and the anterior scalene and the phrenic nerves, right? So if the middle scalene gets tight, that attaches to the first rib. The anterior scalene attaches to the first rib, right? If those get tight and they get hypertrophic and they get thicker, which muscles do when they get aggravated and they get hypoxic, they start to squish the phrenic nerve and they start to pull and push on the sympathetic chain, which directly aggravates and stimulates the sympathetic portion of the autonomic nervous system, right? So again, remember, tissue pathology in general elevates sympathetics. If there's tissue pathology around major nerve systems, those nerve systems become secondarily pathologic to the muscle tonicity and the muscle aggravation and joint deviation, and then it just becomes this whole nasty feedback loop of one thing's bothering you, you get more brain fog or anxiety or depression, or you get more pain amplification, allodynia, hyperalgesia, stuff like that, right? And then it just, each thing, regardless of how it started, continues to drive itself, right, and to drive the other thing. So when the middle scalene and those muscles get tight, they're going to deviate the cervical spine. One of the problems with the middle scalene is it attaches to C2 just like the multifidus and two of the four true suboccipitals do, right? So two of the rectus, the rectus, true suboccipitals, and then the multifidus and the middle scalene, and we got some other smaller muscle attachments there, right? C2 is the most mobile section of our spine. It has about 40 to 45 degrees of rotation. So if I have 90 degrees of rotation, C1, 2, remember we talked about them in segments, so C1, 2 is going to have about 45 of those 90 degrees. And then the next most mobile segment in the spine is also in the cervical spine, but it's only like 10 to 15 degrees. And then once you get out of the cervical spine, the mobility, rotational mobility per segment is under 10 degrees, and it's very minimal in the thoracic and in the lumbar spine. So if we get tight muscles in the cervical spine, by far the easiest joint to get pulled out of place, or the easiest place for our spine to compensate for deviation elsewhere. So if we get deviation at C7, T1 and it gets twisted like that to the right, the easiest way for our body to compensate for that is going to be to rotate C1, 2 to the left, right? Because C1, 2 has so much rotation, it's easy to compensate for other rotations elsewhere in the spine. So if that happens, the trigeminocervical nucleus, which again is in the dorsal horn of the spinal column, that's the bottom part of the trigeminocervical complex, which extends up into the brain and into the neocortex, right? It controls a lot of hormone production function, controls our neuromodulators, and it has a very close relationship with the hypothalamic pituitary adrenal axis, which is one of the other main axes that gets aggravated when our cervical musculature and joints get too pathologic. So the HPA axis, the hypothalamic pituitary adrenal axis, and the trigeminocervical complex both have the thalamus and the hypothalamus as part of the system, right? So the thalamus, and the hypothalamus especially, is in charge of regulating nervous information that's coming to our brain so we can properly process it. And the hypothalamus also has a very, very big part in stimulating neuronal production of different hormones and neuromodulators. So if those parts of the brain get aggravated, and remember the substantia nigra is right near there too, and the substantia nigra, as far as we understand right now at least, is the primary dopamine making center in our brain that's full of dopamine producing neurons. So that's one of the things with Alzheimer's or with Parkinson's disease. When the substantia nigra loses enough of its ability to produce dopamine is one of the reasons that causes the onset of Parkinson's symptoms. And the same type of thing happens from chronic cervical aggravation, is your brain gets very, very dysfunctional, and your dopamine levels, your serotonin levels, your gut health. Remember, the vagus nerve innervates all of our organs, including the intestine, right? So if the upper cervical spine, where the vagus nerve exits out of, is aggravated, that's going to aggravate the proximal section of the vagus nerve, which is going to disrupt its ability to send signals to the organs. So then if the organs aren't functioning properly, then if the vagus nerve is dysfunctional and the sympathetic chain is hyperactive, the brain is not going to be receiving the proper signals about what's actually going on in the organs. And if you're not receiving the proper information, you have no chance to fix anything because you don't have the right information coming in the first place, right? So middle scalene is a very, very problematic one. I really think about that one in relationship to the QL, because the middle scalene attaches the first rib to the neck, the QL attaches the 12th rib to the lumbar spine and the pelvis. So those muscles really, really piss off the rib cage and our ability to breathe, right? So if, again, we could start with just upper cervical pathology. That's going to aggravate the sympathetic chain, which sits right on the front of the cervical spine. It's going to aggravate the stellate ganglion, which sits right in front of the first rib, which is typically considered the upper section of our sympathetic autonomic nervous system, right? It's going to aggravate the trigeminal cervical nucleus, which is going to aggravate the trigeminal cervical complex. That's going to piss off the hypothalamic pituitary adrenal axis. The vagus nerve is going to be inhibited. That's going to lead to inhibition of production of macrophages and other white blood cells and immune system modulators that we need to have in our body. Sympathetic hyperactivity reduces and screws up all of that. So there's so many big nerve ganglia and bundles in the cervical spine, and they're so close to the head that it can lead to all sorts of unusual things. I've seen people lose the ability to see certain colors. I've seen people be diagnosed with Meniere's disease, BPPV, migraines, all sorts of stuff. And I have such a good success rate at fixing people that have had years and years of impairment. They've received regular treatment, but they just haven't received treatment that stimulates the nervous system to change enough. So their nervous system has gone on a runaway train type of thing, and something specific needs to be done that has enough of a sympathetic depressing effect on the nervous system to bring our nervous system back to a homeostatic enough level where it can then self-regulate. And then you can get incredible improvements with anxiety, depression, lots of mental health things, systematic inflammation throughout the body. Remember, vagus nerve stimulation and the upper cervical spine manipulation stimulates the release of CGRP, calcitonin gene-related peptide, from the trigeminal nerve. The trigeminal nerve ganglion are thought to be some of the most potent producers or stimulators of CGRP production, which is a really, really important chemical to vasodilate vessels and reduce blood pressure, increase blood flow. Again, remember, that's something that sympathetic hyperactivity fouls up with. So sympathetics go up, blood pressure goes up, heart rate goes up, anxiety goes up. So we want to depress the sympathetics as much as we can. The cervical spine is a great area to do that. Number one, because the upper cervical spine is parasympathetic and the lower cervical spine has major sympathetic ganglia in it that get really aggravated with tight muscles. So the upper trap, the middle scalene, those muscles sit right near the stellate ganglion, which is the upper extremity sympathetic control center, along with all the other headache causer muscles that are talked about in the literature, like the splenius capitis, the longissimus capitis, the splenius cervicis, the multifidus. All of those things, a little bit of pathology to all of those muscles is going to send negative afferent information to the brain. And the more negative afferent information that's going to our brain, it requires more energy from our brain and our body to process all that stuff. And that takes away energy from our body's ability to do other proper things that it really needs to do, like regulate hormones and neuromodulators and stuff like that. So that's why upper cervical spine can cause concussion-like symptoms, dizziness-like symptoms, stroke-like symptoms. It can cause all sorts of unusual stuff, and needling is the best way to treat it, along with joint manipulation. I like to do my joint manipulation following needling, right? So remember, if you treat the muscles and not the joints, you're only treating half of the problem, because joints don't move themselves, and the same thing the other way around, right? So I like to treat the muscles first. It makes the manipulation easier to do. And then one last quick thing, you guys, on cervical manipulation, right? So the way that I believe you should manipulate the cervical spine is either pushing the backside of the transverse processor and the articular pillar, either pushing it up and forwards or pulling it up and forwards. So the main force of cervical manipulations should be up and forwards, and you can add a little bit of a rotation in there because it does rotate a little. I mean, it obviously turns around itself, but the facets, if my forearms are the facets, the way the cervical spine moves more or less is if I bend to the right-sided facets are down sliding from C3 to C7. The left-sided facets are upsiding from C3 to C7, and the only reason I can keep my eyeballs at the camera is because C1-2 is counter-rotating, right? So if C1-2 is stuck, this is a good upper cervical stuckness test. If C1-2 is stuck, have your patient side bend their head to the right, tell them to keep their eyeballs straight forwards. If their nose starts to go down to their shoulder at all, most likely what's happening is C3 to C7, normal mechanics of side bending and rotation to the same side, so that makes C1-2 the segment that has to counter-rotate to be able to keep our eyeballs forward. So if you side bend to the right like this and your nose starts to go down to your shoulder, C1-2 is not rotating to the left, right? And you may have other issues in there, but most likely that's one of the main things that's going on. So manipulating the whole cervical spine along with the rest of the spine is very, very important. So remember, again, C1-2 is the most mobile segment of the body. I see lumbar deviation cause upper cervical deviation all the time. It happens on me. If I wake up at first thing in the morning and I crack my right lower L5, S1 or somewhere around there, I immediately hear my opposite upper cervical spine cavitate as well, right? So the whole thing is connected. It's just a mechanical thing, physics. The most mobile segment is going to take up the compensation throughout the spine, which is C1-2. That's going to cause muscle deviation, muscle pathology, upper cervical pathology, brain pathology, which can lead to just about anything. All right, guys, thanks. Let me know if anybody has any questions about anything. Talk to you soon.